Hey everyone, we're going to begin. Thank you for coming to the fourth installment of the Responsible Conduct of Research Workshop series. And today's is going to be on the IRB and ethical use of human subjects in research. And I will introduce our presenter in a moment. I just want you to realize that we do have other series that are going on as well. We actually have the third in the series for scientific communication tomorrow, and that's going to be featuring Dr. Yotam Ophir, who is talking about misinformation and, more importantly, AI and misinformation. And then next week, we also have, in this series, we have Dr. Peter Elkin, who is going to be presenting about the safety of your actual data. Data safety is what he's really going to be talking about. And then we also have a diversity type of discussion for scientific communication next week with Dr. Remy Adeleogala. And then there's one more, and I'll talk about that next week in the scientific communication series. I also want to tell you that I'm going to be putting the workshop URL in the chat, and that's where you can find all of our workshops in the CTSI Workforce Development Core. And I will also tell you that there is a micro-credential in responsible research if you're interested. It's okay if you haven't started yet because you get to create your own timeline, and I'll put that information in the chat as well. If you want the certificate of completion that you can get at the end of this series, you need to make sure that you attend all of the workshops, or if you can't attend, I can send you a video and send you a short protocol. So please tell me if you are interested in that. You can either put it in the chat or you can email me. And now I do want to talk about the fact that the IRB and the ethical use of human subjects in research is what the topic of today's workshop is. And Dr. Richard Karalus is going to be presenting for us. He's the director of the Office of Research Compliance, and he is incredibly knowledgeable on this and knows everything that, as far as I can see, that you need to know at UB about this topic. And I'm going to turn it over to him. Thank you.
That is way too much credit to give me. I don't know everything, but I can usually refer you to who does. So I hope to be of help to you and to get everybody on board with human subjects research. So let's begin. Okay, so first of all, I just want to point out that I don't have any financial conflicts or any other conflicts of interest or conflicts of commitment. So next, I just wanted to point out something that happened back in 2018, which for me is like yesterday. For many of you who are younger, it may seem like forever ago, but this is kind of a glaring case of unethical research. So this was a Chinese scientist basically genetically altered babies in China to give them a gene that would make them resistant to HIV. And there were all kinds of problems when this came out. This is the beginning of one of the articles. And right at the beginning of the article, the professor says that, if he carried this research out in most countries, it would have been illegal. He carried it out in China, which has ethical laws. They actually changed them since then. But they didn't have laws that forbade this because they never thought anybody would do it. But anyway, some of the details are that the professor altered embryos of 7 couples, but one successful pregnancy resulted. So, from a standpoint, I'm looking at one of the first issues is what happened to the other 6. Obviously those are potentially people's children that were, didn't result in a successful pregnancy. So that was a huge problem. So there were a lot of problems with this study. First of all, it didn't have any peer review, no safety review, didn't go through the IRB or anything. Again, not because the Chinese, didn't want to regulate this. They just didn't think anybody would do it. So they didn't have regulations on it. But again, none of the research was peer reviewed. Nobody looked at it. There were no significant benefits to any of the subjects. The subjects would have been either the parents or the children in this case. So the children were given a gene that made them resistant to HIV, but they weren't at any greater risk to getting HIV than anybody else was. Their parents didn't have HIV, so they weren't in danger of inheriting it from their parents. Obviously, they're babies, so we don't know if they have any lifestyle issues or anything. But again, the risk on it were much higher than the benefits that they got. And as we all know, genetically altering humans has been relatively problematic. We're getting better and better at it, but we still have a lot of significant risks in the form of cancer and genes that get altered unintentionally. And like I said, the benefits just did not outweigh the risk. In addition, this study, if you want to call it a study, also used subjects that would get additional protections, that being pregnant women and fetuses. We always provide extra protections to pregnant women and fetuses, which they obviously did not get any protections at all. When the PI was consenting people, he basically described to them that he was doing AIDS vaccine development. That was what he said he was doing. Didn't give any information much beyond that to the subjects who signed up for his project. He also worked for several companies that were in the business of doing genetically altered human genes. So he had a significant financial conflict if this worked. So there were all kinds of issues with this. Like I said, this happened in 2018, which is not very long ago from a subjects protection standpoint. I'll give you another one. This is probably the biggest unethical research study that's ever been done and has resulted in the most harm and still is resulting in the most harm. This is, and most people have heard it, the vaccine autism link, which was done in 1998. The study was done by Andrew Wakefield. Used to be an MD. They actually dropped his MD title from him due to this study and not wanting to discredit it. So what did he do? He did a small study that linked the measles, mumps, rubella vaccine to autism. And how he did this study, he used an N of 12 babies or 12 infants. And what he did was he chose 12 infants that had autism and looked at when they received vaccines. Obviously, autism is diagnosed at about the time you receive vaccines. Therefore, vaccines must cause autism. That was pretty much the substantiation of the study. Basically, he looked at 12 diagnoses of autism, saw that that was right around the time that they got vaccinated, and said vaccination causes autism. He also was paid by a law firm that wanted to sue the drug company. You know, this was a time when drug companies were under a lot of pressure. They were spending boatloads of money and drugs costed a whole ton, and people were, you know, very skeptical of vaccine companies and how much money they were working. So he hoped he took this study on, was paid from a law firm that wanted to sue the drug company so that they could make millions of dollars. So since then, there have been over 20 scientific studies that looked at this, his conclusion, and did not come to the same conclusion. So what does something like this do? So you know, it's difficult to overcome perception. We know that even more today than ever. I put this presentation together probably 10 years ago, and we have more people that connect vaccines with autism than ever before, even though this has been debunked over and over again. Like I said, there have been 20 studies using 11 million cases of people getting vaccines to look and see if there was any connection between autism and vaccines, and not one of those studies could find even a far connection to autism and vaccines. So, you know, people tend to grab this and start to think about conspiracies. I mean, in this day and age today, everybody believes in a conspiracy theory, it seems. So, you know, even you point out the facts. Like I said, anybody can go and see, you know, all of these studies and look at the facts and everything, but they don't trust them. Oh, these are made up or whatever. You know, there were even people who said, okay, it may not be the vaccine. It might be the preservative that they use in the vaccines. They use thimerosal, which is a mercury-based or did use thimerosal, which was a mercury-based preservative in many vaccines And people said, well, maybe it's not the vaccine, but it's the mercury in the thimerosal. We all know mercury can be harmful. And so that's probably what it was. Well, the MMR vaccine never used mercury. It had a live strain that was in the vaccine that was in question. And obviously the thimerosal would have killed the live strains. So they couldn't use thimerosal in that one if they wanted. But a lot of people, still connect mercury with the vaccines with autism. This leads to a distrust of the authorities. Like I said, as we're seeing even more and more. I mean, just look at the measles outbreak that's taking place in the South and Southwest. People just don't want to get vaccinated, and this is kind of the whole study that began it. It started with COVID-19. There was a lot of people who didn't want to get vaccinated during during the COVID pandemic, which slowed our recovery to that. Now, actually, at the time I put the slide together, which was a few years ago, about 10% of parents refused vaccines. I would come up with all kinds of religious excuses and such, and that still goes on today. And people also don't want to look at the historical link. So back before vaccines were in place, about a third of children died before they reached puberty. So back then, the age expectancy for a human was in the mid-40s. And the reason wasn't because people didn't live to old age. There were a lot of adults that lived to, normal old age in their 60s, 70s, and even beyond. The reason why the life expectancy was so low was because a third of the children were dying off before puberty. About a quarter of children die off before they even get out of infancy. And people just don't understand that that's the risk that they may take if they forego vaccines. Herd immunity is also something that you need to consider. If there are still children who may get vaccinated, but just may not respond to those vaccines for whatever genetic reason. If we don't have herd immunity, which just keeps the level of disease down in the general population, then those people are going to be exposed to more and more chances of getting the disease and perhaps passing away from the disease. And a good example is actually about a month ago in my school district. I'm a board member. One of our 9-year-old students passed away from the flu, just generic flu that's out in the community. Obviously, she had some, most kids get the flu, even if they're vaccinated or not vaccinated, and recover from it just fine. She happened to be one of those unfortunate people who had a bad effect to it and passed away. And like I said, if we had more herd immunity, perhaps she never would have been exposed to flu. With diseases that are even more harmful, like measles and other childhood diseases, the toll is going to be even worse. So let's get back to ethics. So what is ethics? Ethics seems pretty easy. It's the discipline of dealing with what is good and bad with moral duty and obligation. It seems like a pretty, easy thing to follow. But I'm hoping I'm going to put more questions into your mind than I may put answers. And that's a good thing, because that will get you thinking when you're doing your own research. It's maybe not so cut and dry. So what exactly is ethical? It's consideration of what is good, bad, and acceptable. And, we would think that's intrinsic. So, you think about it, okay, things like, it's bad to kill somebody. Well, what happens if that somebody happens to be attacking your family or your child or something? Then does it now become ethical to maybe kill them? What about war times? Is that ethical to kill your fellow human being? I don't have the answers to that, but now all of a sudden, well, okay, maybe killing isn't such a bad thing under certain circumstances. So, things like that. What drives ethics? It's experience also. It's personal experiences. Different people will consider different things as more acceptable or less acceptable based on their personal experiences. If you've had somebody die from a non-vaccinated person, then you may feel very strongly about vaccination versus somebody who maybe has no real experience or knowledge about vaccines, who just heard the vaccine autism link and thinks it's a bad thing. Also, society, tells us what's ethical. We can surely see that, in this day and age. Like I said, I put the slide together years before today, and if we look at our society today, it seems like our ethics are changing very quickly and very different from what, even 10 years ago we would consider acceptable and not acceptable. And I'm not going to say not right or wrong. I'm not going to get into that because that's something that we all need to decide, as a group and as individuals as to what is ethical. We learn ethics from our peers, the people that we work with, our leaders also. I mean, look at our leaders now, the changes in ethics from, leaders past to leaders now and probably leaders in the future. Time period, like I said, when I put this slide together, ethics were a whole lot different than they are today. And technology is also another driver of ethics. Think about the first case that I brought up, the genetic alteration of the fetuses. 10 years ago, 20 years ago, that would have been unthinkable. We wouldn't have been able to do that. We wouldn't even had those questions. But today, because the technology is advancing, it is coming into play, and it will come even into more play as we become more advanced. So why is ethics important? So ethics is important for a number of reasons. First of all, it satisfies our need for fairness and honesty. Everybody wants to be on the same playing field when we're dealing with things and do what is right and wrong as we see in society and do things properly. It develops trust between people, creates your own credibility. If people think you're an ethical person, they're going to trust you, maybe even give you some benefit of the doubt that they might not give somebody who they didn't have in as high in ethics standards. It also develops your reputation. It improves your good decision-making abilities, hopefully, helps you accomplish goals, and it also unites people with common goals. So there's a lot of good reasons why we want to be good, ethical people. So let's talk a little bit about research ethics. We'll switch gears a little bit and talk about why it's important in research and what to look for when you're trying to make good decisions. So first is consideration of your research topics. There are a lot of different topics that we can choose to study in research. Most of them are good. Some of them are bad. We have a lot of acceptable, research topics, curing cancer and, doing genetic modifications that will help people. Want to make sure that they're beneficial or at least not harmful. And by at least not harmful, if we pick a research topic that we want to study out of curiosity, we want to make sure that we're not harming people. You wouldn't want to pick something like eugenics or something of that nature as a research topic where you're looking to harm different people. Also, when we're doing research, we need to kind of take into consideration our research methods. They may be limiting for what we can do, and I'll have a couple of case studies where we'll look at that. But, if you needed to, if you could come up with a cure for cancer, but in order to come up with it, you needed to, it would result in the deaths of 100,000 people. Well, is it ethical to come up with that cure or not? I'm not going to give an answer positive or negative on that, but those are things that we take into consideration when we talk about ethics with research. One of the most important things is data integrity. Data integrity is huge. The reason for data integrity is there's a lot of pressure on people to publish and to publish positive results. And I've been a researcher myself for years and years, and probably you've gotten more negative results than positive results. And negative results aren't a bad thing. They guide us in the right direction. But everybody, wants to publish positive results and the best results. And there's a lot of pressure to do that for granting and your reputation and moving forward in the field of research. But that pressure also comes with a lot of responsibility. So, we've all done research, or many of us have done research, and you may do research in the future, and you'll do your experiments time and time again to prove that they're repeatable. And when it comes down to time to publish, we all tend to grab the best results and publish those, the prettiest pictures, the best data, and everything like that. And there's nothing wrong with that as long as the rest of your research supports that. So if you did an experiment, 10 times, 9 times it failed, and 1 time it was successful. Obviously, it wouldn't be a very good idea to publish those results because, 90% of the time it didn't work, and you can't just cherry pick and ignore those results for the, for the best results that support your theory. And one of the reasons also because that provides kind of a foundation for the next people's research. We tend to trust our peers when they publish something and as kind of fact. It may not be fact. It does need to be repeated, but nonetheless, nonetheless, we give our peers a lot of the benefits of the doubt if they're doing, or the benefit of the doubt if they're doing good research, and kind of do it as facts. So we base our research on their results. If they're publishing bad results, then we're basing our future research on bad results. And that can set science back a huge way. It wastes money. It can cost people careers and advancement, grants, and everything. So when you publish, make sure your data is good. Make sure your data supports your hypothesis, and that's probably one of the most important things that I can't stress more when we're doing research, is make sure what you publish is based on fact, and not just one fact out of 10 where it didn't work. So, take care to do that. I know we're all under a lot of pressure. Another thing to consider in research is whether to share or not to share your data. So say you come up with the cure for cancer, and you're working with Pfizer to get a patent on it and get some contracts and make a lot of money. And there's nothing wrong with that. But let's say it's going to take a couple of years. Do you not share that cure for a couple of years, knowing that people will die waiting for you to be able to use your discovery? I don't know. So you need to kind of balance your personal gain from societal benefits when we're making those decisions. And I can't give you good advice because I don't have good advice. You need to kind of balance that with the benefits versus the risks, and we'll talk a little bit more about that in the future. So now I'm going to switch a little bit more to compliance on a regulatory side. Why is it important to be compliant on the regulatory side? We have that nasty IRB there that always wants to give you a hard time and make it more and more difficult on you to do research, and it takes a lot of time and energy to put together and get your research approved. And what is one of the reasons? The reason is because we're under a lot of pressure. The IRB is under a lot of pressure to do things properly. So here are some examples. These are later examples, but we've also seen more current examples. So back in 1999, this was a time when we had our current or most of our current regulations in place, but nobody really paid a whole lot of great attention to them. Yeah, they were all there in our policies, but it was pretty easy to get your IRB through. I've looked at UB protocols from back then, and they might have been a page or two of a brief description of what you want to do, and those got readily approved back then. OHARP, which is the Office of Human Research Protections, soon began to realize this, so they started doing more audits and looked at medical centers, and they tended to choose the big ones because they knew that they had a problem and they wanted to make a big splash. So the first one they looked at was Duke University. Duke is huge, thousands of human research studies, hundreds of millions of research dollars. So they went and did a random site visit, and when they looked at Duke, sure enough, they had all kinds of serious deficiencies. And basically did what they do when they come for site visits. They gave them a huge list of things that they needed to take care of and get fixed. And they were obviously coming back for another visit, and they made it a 6-month visit. When they came back in 6 months, they saw barely anything done. They saw a long, drawn-out process, a few changes here and there, but nothing major. So OHARP decided that we're going to make a big splash. They shut down Duke's human subjects research program, just shut it down until Duke addressed all of their shortcomings. I mean, can you imagine that? UB has over $400 million worth of research, federal research dollars. Can you imagine if they came in and shut that down? There'd be a lot of issues. We've got a lot of people who work on those federal dollars, and we don't have that much money to cover those people. So obviously, we need to make sure that we are on the ball with our research program. So the OHARP's director basically said this was a failure of leadership. They just didn't care about it. Just thought, oh, we'll glaze over a few changes and show that we're making some slow progress, and they'll let us go like they always did in the future. And like I said, at this time, OHARP realized they had a huge problem, and it didn't end there. Next one they looked at probably one of the biggest in the country, Johns Hopkins, in 2001. So there was a young woman, Ellen Roche, who was a healthy 24-year-old person who volunteered to take place in an asthma study. She was given an old drug called hexamethonium, and the drug tended to induce mild asthma attacks. However, with Ellen, she had some serious problems within the first 24 hours. She lost a third of her lung capacity, and within a month, she was dead, a healthy 24-year-old volunteer. So OHARP obviously got wind of this and looked and wanted to see what was wrong, and I'll tell you why. So they looked at how this study was put together and how it was reviewed. And there was a PI, Dr. Tagayas, who only looked at a couple of contemporary textbooks when he was looking at the effects of hexamethonium, and he used PubMed. And at this time in 2001, PubMed only went back 10 years. So they only had about 10 years of data in PubMed. He went through PubMed because it was easy to do. You know, it's easy to do a PubMed search. You go online, put in your keywords, and he looked at hexamethonium and didn't find any side effects or any bad things. Well, the side effects of hexamethonium were identified back in the 1950s, and it was published, you know, in early journals, which weren't in PubMed, about the potential bad side effects that this drug caused, and that's why it wasn't in use. So anyway, this was also, I want to point out, was approved by the IRB at Johns Hopkins. So nobody in the IRB looked back and saw, okay, what are the risks of hexamethonium? That's one of our jobs in the IRB, is to look at and identify a risk that a PI might miss. So OHARP again came in and, they found that the PI didn't see this, and even worse, the IRB didn't see this as an effect. This was well known to, people, a lot of people in the asthma field, and should have been known to the PI. So they shut down Johns Hopkins in 2001. Again, another 2,400 studies, 15,000 human subjects at Johns Hopkins, just shut them down. This was great because some of those subjects were on, drugs, research drugs, and had their research drugs discontinued. So they were, kind of lost in the middle of the study. And, if you discontinue a research drug also, that study is pretty much done, pretty much has to be started over in order to get any effects. So it cost Johns Hopkins a lot of money and a lot of credibility, one of the PIs, professors at George Washington University, just said this is just laziness. It's not only an indictment of the PI, but it's an indictment of the whole system. They should have caught this. Not only should the PI have caught this, but the IRB should have caught this. So these were the two shots across the bow for everybody to get on board and basically revamp their human subject systems and get compliance. And a lot of that happened here at UB as well, which is kind of tells you why our process seems like it can be a little bit drawn out and difficult to go through. So now I'm going to change gears again, and we'll go through some history of compliance. So where did all this done? We've been doing research on human subjects for as long as mankind has published. You've heard about Jenner, vaccinating a child with cowpox to prevent smallpox. He didn't have any IRB, he didn't have anybody regulating him, and studies have been done well beyond that. But I'm going to pick it up right around the time of World War II, because that's kind of when modern regulations started to come into being. So after World War II ended, and we moved into a lot of the prisoner camps, we realized that the Germans and the Japanese were doing a lot of human experimentation on POWs, American and other countries' POWs, and also on the countries that they occupied. So a lot of the countries, they would just basically take people off the street and use them for their human experiments. And what were they looking at? They were looking at really nasty experiments, bone, muscle, and nerve transplantation. You're looking back in the 30s and 40s, head injuries, freezing experiments where they infected people with malaria and other infectious pathogens. They exposed them to mustard gas, sulfonamide, which is another nerve agent. They injected seawater into people. They burned people with phosphorus did all kinds of blood coagulation studies, and many of these studies weren't at all regulated in any way. There were a lot of people who died from these experiments. But when you look at these experiments a little bit closer, when you look at ethics, there's one thing that all of these experiments have in common when you dive a little bit deeper. All the subjects of these experiments had to do with warfare. So, as their soldiers were in combat, they were seeing a lot of injuries. They had issues with pilots going down in cold water, hence the freezing experiments. They were fighting in environments where malaria was causing more casualties than battle injuries. In the case of the Japanese, they were using germ warfare, so they wanted to know how their weapons acted. Injections of seawater. It sounds horrendous, but people were looking at if you had casualties out in the field, it was very difficult to carry either blood or saline. It took up a lot of space and weighed a lot. So people were thinking, well, maybe if we could just inject seawater or use seawater and dilute it down to the proper concentration of saline, we could use that in lieu of saline. Hence why they were injecting seawater. Obviously, burns and coagulation experiments for treating burns and also wounds where they had trouble bleeding. So it wasn't just for curiosity's sake. It was actually, they were doing these experiments to try and save their soldiers. Unfortunately, it was to the detriment of all the people who were in the studies because they had no rights when it came to doing the human subject studies. So what did that result in? That resulted in the Nuremberg Code in 1947 after the war had finished. And these are basically a lot of the same tenets that we use in our research regulations today. Excuse me. So the points of the Nuremberg Code were, it makes a lot of sense. Voluntary consent is absolutely essential. You can't just go and grab people off the street or grab people from wherever and have them be in a study. You had to ask them whether they wanted to be in the study and give them information on the study before they would volunteer. Your research also had to have scientific merit and be for the good of society. Obviously we don't do studies for just out of curiosity when they don't have any benefits to society, especially if there are risks for the subjects. Human experiments should also be based on the results of animal experiments and also have a knowledge of the disease. We don't want to just go, with no thought and start with humans. If we can start with an animal, we want to do as much animal experimentation and get as much data out of the animals before we ever move to a human. And we want to make sure that those animal experiments we do are valid, that the results will relate to what happens in humans. You can infect a lot of animals with a lot of different bacteria or viruses, and some may get infected. Some may not get infected at all. Others may get infected, but the course of the sickness looks totally different than humans. So we need to make sure that we pick a good animal model of disease when we're trying to associate the data back to human experiments and know what's going to happen. The experiment should also avoid unnecessary physical and mental suffering and injury. We want to make sure we minimize that to every possible degree we can. No experiment should also be conducted if there is reason to believe that death or disabling injury may occur. Obviously, that makes a whole lot of sense. And the degree of risk of the experiment should never exceed the importance of the problem to be solved. Again, we talked about kind of the cancer issue. If it takes 100,000 deaths to find the cancer cure, well, maybe we're not ready to find the cure just yet. Proper preparations and adequate facilities should be available to protect subjects from injury, disability, and death. So, if you're doing a drug study, you better have medical facilities or a doctor available that can treat any side effects. If it's something that has to do with being in a hospital, you better have a hospital standing by. If it's something that needs psychological support, you better have that psychological support standing by in case you need it. Experiments should also only be conducted by scientifically qualified persons. So, the inventor of a of a brain stent might be a PhD, and obviously a PhD is not qualified to put a stent into a person. So we need to make sure we would have a person who is properly qualified to operate on people and perform surgery on persons rather than just animals. Human subject has the right to discontinue participation at any time during the experiment. So at any point during the experiment, somebody can say, you know what, I don't want to be in this study. Sometimes you may have to provide them additional support. You may have to wean them off of a drug, or if they have a device or something, you may want to talk about allowing them to keep that device in there and monitor them, even if they don't want to be part of the device, or remove the device in some cases if they so choose. And also, the scientist has the obligation to discontinue the experiment if they find that their experiment is likely to result in injury, disability, or death. So they can't just keep going. If they have a death on hand, they may have to stop the study or suspend it until they figure out whether that death was attributable to the study that they were performing. So this sounds like these are great regulations. Again, they seem to address most of what we go by today. And did they work? Well, not so well. So these are experiments that were done right here in the United States, and there's a list of them, and this is a short list. I had a huge list that I couldn't fit in. I would have had 3 or 4 slides of this, but these are just some of the more drastic ones of U.S. experimenters who did work, fully knowing about the types of experiments that were done in the concentration camps and Japanese prison camps and such during World War II. So we have John Cutler from Johns Hopkins University. Again, a great university. He was using prostitutes that were infected with syphilis to infect prisoners, and same asylum patients and soldiers to test penicillin. And he did these experiments in Guatemala. The reason why he did them in Guatemala, because he wouldn't be allowed to do them in the U.S. 1946 through 1953, our Atomic Energy Commission was feeding mentally disabled children Quaker oats that contained radioisotopes, because this was the time when we had just invented the atomic bomb, and they wanted to know the effects of radiation and the radioactive isotopes that were produced by the bombs on people. In other words, are the bombs safe to use? The children were told that they were joining a science club. 1953, in the U.S. Army, they were regularly exposing soldiers to sulfur mustard and nerve agents gases. The soldiers were not volunteers. They weren't even told of the test. They were basically just put in a chamber and exposed to the agents. At that time, they were considered, U.S. soldiers were considered U.S. property, and they figured they didn't have to even consent them because they're U.S. property. They don't need to ask them whether they need to want to be in the test. 63 through 66, Dr. Krugman from New York University, again, a well-known institution, infected mentally disabled children with viral hepatitis at the Willowbrook State School. He told the parents of those children that he was giving them vaccinations. 1963 through 73, Drs. Heller and Hamilton irradiated the testes of prisoners to determine the effects of radiation on testicular function. I mean, by those times, in the mid-60s and 70s, we already knew the results of what was going to happen if we exposed testicles to radiation. The one PI, Hamilton, stated the experiments had a little bit of the Buchenwald touch to them. So he knew he was doing wrong. He knew he wasn't following the Nuremberg principles. And the final one I'll just bring about is 1965-66. Dr. Kligman was performing dermatological studies on prisoners with dioxin. So this was the time of during the Vietnam War when we were using Agent Orange, which was contaminated with dioxin, and we knew we were having issues with it. So he decided that he was going to use prisoners because they were easy to get at. And when he was asked about why he was using prisoners, he was told, "All I saw before me were acres of skin. It was like a farmer seeing a fertile field for the first time." Doesn't sound like he had the interest of the subjects at heart. Looked like he had the interest of Dr. Kligman at heart. And again, so why didn't the Nuremberg experiments or Nuremberg principles work in the United States? Well, the reason was because of our arrogance. We felt, it was those nasty German and Japanese who don't have good ethics. We in America, land of the free, we are a higher level. We wouldn't do such things. All the research we do is for the best interest of people. And in some cases, that's the way these people thought. Well, we are sacrificing these people, but we're getting very important data from our experiments, and they never thought about the subject. So. The biggest study, which I'm sure everybody has heard about, is the Tuskegee syphilis study. This is kind of like what broke open the regulations that we needed better regulations in the United States. So some details on the Tuskegee syphilis study. This was started in 1932 and ran through 1972 for 40 years. The simple goal of it was to record the natural history of syphilis to justify a treatment program for Blacks, for African Americans. And it was supposed to last 6 months. Again, went 40 years, supposed to last 6 months. So what were they told? Again, you're talking about the 1930s. They went back into rural southern districts. The people who they were trying to get into the study were, for the most part, sharecrop farmers. Most of them couldn't read or write. And they were basically, the researchers would come in and tell them they were being treated for bad blood. That was the nature of the description of what they were doing. And what were they given for it? They were given free medical exams, free meals, and burial insurance. So at the time, syphilis was pretty much, if you got syphilis, you died of syphilis. So there was no cure for it. There was no treatment for it. So, these people knew they had syphilis, or, well, I shouldn't say they knew they had syphilis. They didn't even know they had syphilis. They just knew they had medical problems. And so they went for it. Hey, I get free medical exams and treatment. I get free meals while I'm there for my exams, and burial insurance. Burial was expensive back then. They didn't have a lot of money. They were all poor African Americans, and they thought this was a great deal. Again, I said it was only supposed to last for 6 months, and they had good goals. They just wanted to see how syphilis progresses, to see if they couldn't come up with a good treatment. But they took this beyond what would be considered ethical. So, in 1947, we invented antibiotics. Penicillin was on board, and other antibiotics were coming fast and furious, and we soon had proper treatments to cure syphilis. Well, the subjects weren't offered any of the cures for syphilis. They weren't even told that there were cures for syphilis available. They were just allowed, their disease was just allowed to progress until death. They were never given the opportunity to quit the study, were never even asked if they wanted to continue. This study didn't end until 1972, and the reason is because the Associated Press broke the story, published it, and there was public outcry, and that's when they ended the study. Otherwise, God knows how long it would have gone on, but totally unethical. Like I said, we could have easily cured these poor people and let them go just for curiosity's sake alone. So what happened? The U.S. government knew they had a huge problem back then, so they formed a committee called the Belmont Committee, who looked into what regulations we wanted to have, and they came up in 1979 with the Belmont Report. And the Belmont Report has a lot of the Nuremberg principles in it, and even goes a little bit deeper than the Nuremberg principles, and defines those principles a little bit better. So it's based on three pillars. Respect for persons, beneficence, and justice. Respect for persons is giving people information, making sure they comprehend it, voluntariness, and privacy. Beneficence is the assessment of risk versus benefits, and also the minimization of risk. And justice has to do with the selection of subjects for your study. And I'll go through each of those pillars a little bit more in depth. So respect for persons. What is respect for persons? This is giving them all the information, full disclosure, basically a full description of your study, the goals of the study, describing the procedures, any alternative treatments that might be available outside of the study, any conflicts of interest you might have. If you're working with a drug company and they're paying you to do the research, then obviously that we would consider a potential conflict of interest. You need to tell your subjects that you're doing it because you're getting paid for it. And any cost to the subjects. And, the cost can range from, if you get hurt, we're not paying for your injuries, to just every time you come over to Buffalo General, you're going to have to pay $15 or more for parking. So things like that. Comprehension, really important. You need to make sure that the consent and the descriptions that you provide people are in layman's terms, the terms that your subject understands. We've all watched those old movies from the 50s where you have doctors come in and they use Greek and Latin terms that even we don't understand, and they sound really intelligent, and you just tell them let's do whatever you feel is best for me without ever understanding what they're doing. That's not allowed anymore. It needs to be make sure that it's layman's terms. And when you do consent, it needs to be a two-way discussion. You can't just hand somebody a consent form here, read this. And you need to make sure it's a two-way discussion. You need to make sure after you hand somebody the consent form that they read it, make sure that they understand it. You have to make sure that they understand it. Go through it with them. Make sure there's no misunderstanding. Make sure that they understand all of the terms and stuff like that. When studies go through the IRB, that's one of the things they will look at. If you have a consent form that sounds too complex, they're going to ask you to change the language in it. And it needs, like I said, to be a two-way discussion with the subjects. Voluntariness. You need to make sure there's no penalties if a person opts out. You can't say, I'm running my office, and as part of my practice, I'm doing this study, but if you decide not to be in the study, I'm not going to give you treatments. You can't do things like that, or change person's treatment or the way you treat them normally if they choose not to be in one of your studies. Also need to make sure your recruitment is not coercive. The subjects need to participate for the good of the study. You can't push them into being in a study if they don't want to be. And need to make sure that subtle forms of coercion aren't there. So if you're running your office and you're also running the study, chances are the IRB is not going to allow you to be the person to consent those people, because you're their treating physician, and they want to make sure that they're doing good by what their physician asked them to do by. So that's considered slightly coercive if the PI is also the treating physician. They may have a nurse or a different doctor ask them if they want to be in the study. So things like that are a little bit more subtle that you might not think of. And respect for persons is also has to do with privacy. Privacy is different from confidentiality. When you fill out an IRB form, there are going to be two things that we ask for, and sometimes we get the two mixed up and think that they're one and the same: privacy versus confidentiality. So confidentiality, the easiest way to differentiate them is confidentiality has to do with the records. So anything that you collect on a person, anything you write down, those are considered records, and those can have confidentiality issues. Privacy is between you and the subject. So privacy has to do with you talking with the person, making sure you do it in a private area. So if you're consenting somebody, say you're in a infectious disease office, you don't want to go out into the office and say, "Hey, Mr. Jones, understand you want to be in the HIV study. Could you come back here and we'll talk about it?" Meanwhile, while there's 100 other people sitting in that office area, that would be a huge breach of somebody's privacy. So you need to make sure that discussions take place in a private room. You'd obviously be letting lots of people know that all of a sudden, Mr. Jones is HIV or maybe HIV positive, which may add stigma and issues. So things like that have to do with privacy. All right, so beneficence, the second pillar of the Belmont report. What does that have to do with? That has to do with mainly risks and benefits. So need to make sure when we look at a research study that the benefits outweigh the risks. And that can sometimes be a little bit difficult to do. There are sometimes benefits to an individual versus benefits to society, and the risk may not go hand in hand. So an individual may be put under risk when there's no benefit to him, but the benefits to society are huge. So, for example, I'll take somebody being in say there you want to enroll somebody with an alcohol problem into your study, and you're basically just doing some surveys, seeing how they develop their alcohol problem, treatments that may have worked or may not have worked for them, and kind of to determine which treatments work best, which didn't, what led this person to alcoholism and such. And that's the end of your study. So the risk to the person could be, maybe he keeps his alcoholism, secret and doesn't want anybody to know. So there's a huge issue with confidentiality and privacy. He doesn't want people to know. But the benefits may be to society in that, you can identify 3 treatments that absolutely don't work and 3 treatments that absolutely do work. So, the risks are to the risk are to the individual, the benefits are to society. So it's not always just a risk versus benefits thing to the individual. Also, minimization of risk. This is something that the IRB looks really close at. Whenever somebody's in a human subjects research, even if it's a minimal risk study, there's always risk, and I'll kind of go through that in more detail. But there's always going to be risk, and we want to make sure that we can minimize those risks to the highest degree before we do the study. There's always risk, but if we can get rid of 1 or 2 risks, hey, that's what makes it a better study. Also, things like controls. If you have a control group, say you're testing a cure for cancer, your control group cannot be persons who are totally untreated. The persons in your control group cannot receive less than the standard of care. In other words, whatever the best treatment available today is, that is your control group, and you are testing against that group as a control group. You can't withhold treatment just to see if your treatment works or not. You need to hold the level of treatment to what is available. Also need to make sure that before we ever look at a human, I talked about this before, need to do testing on animals. Need to make sure that what we're testing, if there are risks, that all of the risks have been worked out in animals and that you've demonstrated efficacy of whatever your study is looking at in animals to the highest degree before we ever look at a human being. And also, consideration of individual subject sensitivities. I kind of talked about things like HIV and alcoholism, things like that. So you may be doing, like I said, a simple survey and thinking, oh, this is a totally benign study, but there may be sensitivities that the subject does or doesn't want people to know about, and those can be more or less serious, but we need to take those into consideration. So the last pillar is justice. What is justice? Justice has to do with the selection of subjects. This has always been an issue. You can see it in the past studies that I've shown. People are always looking to mental institutions or other institutionalized people, prisoners, because they're an easy collection of subjects that are in one place. You don't have to chase them down. In a lot of cases, they don't have anybody looking out for their well-being to a higher extent, and things like that. So we need to make sure that our selection of subjects is fair. We're not just picking, poor people because we're offering them $50 for a cancer study where nobody else would even think about, that level of money, but somebody, who was poor and destitute might jump at that, even though the risks are huge. So we need to make sure that the subjects that we're picking in our studies are also the benefactors of our work. So we don't want to be testing a huge, risky, let's say, plastic surgery topic and give, people who are destitute, homeless, we'll give you $1,000 to test this. We know the risks are huge, but they'll jump at that immediately because they're never ever going to be able to afford or even probably want to do plastic surgery, but they would bear the burden of your testing program. So if you're testing something like that, you need to go and make sure that you're recruiting from the group of people who are going to be the benefactors of your work, that they're not bearing the burden without seeing any of the benefits. That's what justice is. All right, so now I'm going to change gears a little bit, and we're going to go into the review of human subjects research, the dreaded IRB that everybody loves and looks forward to submitting your study. What do we do? Why do we do what we want? And what are we looking for? So the first question I get, this is probably one of the most questions I get most often. What do I need to submit? Does my study need to be submitted to the IRB? Can it be considered not human subjects research? Is it exempt? And the answer I'm going to give you if you're asking me this question is submit it to the IRB. Because if you have questions, then I definitely have questions because you're probably not giving me 100% of the details. You want the answer that no, you don't need to submit it to the IRB. And you know what? Dr. Richard Karalus, the director of the, Office of Research Compliance told me I didn't need to submit it. So, blame him when it's found out that it is actually human subjects research. But there's reasons beyond that, even that make a lot of sense for me telling you that you need to submit it to the IRB. So even if your study is not human subjects research, even if you're quite positive that it's not human subjects research, or you think it's a quality improvement project, which is also not human subjects research, there are reasons for submitting it to the IRB. We're seeing more and more journals come to our investigators asking, hey, was this study reviewed by the IRB? Even if it's not human subjects research, they want to see a determination that it was looked at, and the IRB came up with the determination that it's not human subjects, and it wasn't just an investigator who said, yeah, it's most likely not human subjects research. So that's a huge reason. Most reputable journals are going to ask for IRB review and approval, or at least a determination that it was not human subjects research. And you can get, if your study is not human subjects research, the IRB can look at it and tell you retrospectively that, oh, yes, we'll give you a letter. Yeah, that was not human subjects research. But every so often, maybe a quarter of the time, we'll look at what somebody thought was not human subjects research and realize, ooh, this did qualify to be human subjects research. It may have even been considered exempt, which is the lowest determination of human subjects research, but it was research. If we find that you did research without going through the IRB, that's serious noncompliance. We have to report that to the federal government as soon as that determination is made, and that goes with your name to the federal government. You were just found of serious noncompliance. Your name is now submitted to OHARP. You have a record of doing research without approval. So we cannot give retrospective approval of the research, even if you did it properly, even if you came up with the greatest of consent forms and the greatest method for enrolling people, the safest method. If you didn't get that IRB approval, you did research without approval, and I'm obligated to report that to the government. And that happens about once or twice a year that I see that taking places. So a lot of times you're going to look at our huge study protocol. It's called the HRP 503, and it's got about 30 questions with sub questions, and it's some 20 some pages long. And what you're doing is just an easy survey. And you're going to say, oh, God, I have to fill out this whole long 27-page thing. Well, you do, but you don't. There's going to be a lot of the sections that are just considered not applicable, and you could just put not applicable. So you may only be filling out maybe 5 or 10 of the basic questions and submitting that for IRB approval. So it's not as bad as you think it is if you've got a simple study. Submit it to the IRB. We have great review times that are in line or better with a lot of the with the average that is in the country. So it should, if it's a simple study, we can get it approved in about 2 weeks. So it doesn't take that long to get approval. If it's a more complex study that is significant significant risk, then it's going to take a bit longer, about maybe a month and a half or so average. All right. So, sorry, here we go. Okay. So why do we have all of these, why do we ask all of these questions at the IRB? It's not just because we're curious. It's not because we want to make your life difficult. It's because we have to meet a lot of regulations. We have to meet the FDA. We need to meet Health and Human Services, which are similar but different. They both have a lot of similarities, but they have differences, and that's unfortunate. They could be one and the same, but they can't. They're like federal agencies. They can't agree to come up with the same. Then there are also state laws, especially here in New York State. We have additional laws that cover human subjects protections. We also sometimes need to look at the HIPAA regulations. If you're looking into the medical records, HIPAA will now apply. Sometimes there are local UB or local laws that may apply. We're also an accredited IRB, so we have AHARP, which is another layer of added regulations and responsibilities we have. We have our FWA, which are federal wide assurance. Sometimes institutional requirements, sometimes sponsor requirements. We did make sure that your study is in compliance with all of those. And that's the reason why we ask you so many questions and come back with additional clarifications. It's not out of curiosity. We have checklists on all of this. You can go on the on our compliance website, and you can see all of the checklists that we go through when we look at your study. And we need to make sure that we can check all of those boxes. And until we can't approve your study. That's the reason why we're constantly asking for clarifications and changes in your study to make sure that you meet those requirements. So when the IRB reviews your study, types of IRB determination. So basically there's 4 determinations you can get from the IRB. You can get a not human subjects research determination. If you're dealing with all anonymous data, you go to a data repository and it has all kinds of anonymous data that's available to the public, no way of re-identifying the subjects. And you want to do research on that, you can do that to your heart's content. You can't re-identify anybody, though the topic is low risk. That will be considered not human subjects research. If you're doing a quality improvement program, say you're in your physician practice plan, and you want to know there's a couple of different approved treatments. You want to know which one works best in your particular practice plan. You can go and do that. You can compare which treatment works better in your practice, and that's not considered human subjects research. Now, a lot of people, when they do QA/QI programs, say, hey, you know what? I think this is going to be useful for other practice plans. And this is really interesting what I found. I want to publish this now. Well, that's when you start getting into the human subjects research program. A lot of times we're going to say, you know what? No, you can't publish that because there are risks to the people who you were looking at in your practice plan. They may be re-identified because, maybe it's a rare condition, only a few people have it. And there will be, doctors in the community who will say, I know who that is. That's Mr. Smith because he's the only guy in Western New York who has this case or something like that. So those are times when QA/QI may not be able to be published. In some cases, you can publish QA/QI with it still remaining not human subjects research. But again, that's an IRB determination. So we may say, oh yeah, you did the QA/QI study, you'd like to publish it, but you know what, you can't because it was research. If you want to do the study again, you're going to have to apply for IRB approval and redo the study because we're not going to let you use the data that you got from the original QA/QI study. And that's why when you ask me, should I submit this to the IRB? Yes, the IRB may look at it and confirm exactly. You could even ask the IRB, I want this to be, a QA/QI program. They're going to look at it with that eye on the study and say, okay, yeah, it is a QA/QI program. You covered your butt. Now you can publish it to your heart's content. If the journal asks you, you've got your letter. The IRB reviewed it and found it to be not human subjects research. So if it's not human subjects research, you're free to go. The next 3 levels determinations you can get are all considered human subjects research, and some are considered minimal risk and others are more than minimal risk. So the 2 minimal risk determinations you can get are it can be an exempt study. So it's human subjects research, but it's exempt from the regulations, meaning that you don't have to submit a continuing review. What you do need to submit is if you make any changes to your study, because especially if the changes may affect the determination of the study. In other words, if you add more risk into your study, just because it was determined to be exempt, if you make those changes that add more risk, you want the IRB to look at your determination again and approve that modification. And they'll say, okay, we're approving your modification. It's still an exempt study. But in some cases, they may say, we're going to approve your modification, but now this bumps your study up into the expedited category. So even though you may not have to do continuing reviews, if you make any changes from what you submitted, you should submit those to the IRB for further review. So exempt studies are minimal risk studies. There are 8 categories. I'm not going to go through those 8 categories that we can exempt them. These are very minimal risk studies, things like surveys on various things. And the survey topics you pick, there aren't a huge number of risks. It's nothing like an alcoholism survey or an LBGT, sorry, I get that wrong, type of study where there might be additional risk where it might bump it up on another determination. And the one thing I want to add about exempt studies, and you may not understand this right now, but sometimes IRBs can rely on different IRBs. So if, we're doing a study with 10 other universities, there may be one university that's serving as the reviewing IRB, and a lot of times we'll sign what's called a reliance agreement and allow the lead university to become the reviewing IRB. We can do that for expedited reviews, and we can do that for full committee studies. We cannot do that for exempt studies. And the reason being is because exempt studies, I told you we have 8 categories. Well, there are a number of categories that UB cannot use just because of the way we're organized, and also being in New York. Being in New York means that we have to look at all studies, regardless of funding, and determine whether they're exempt. So one of the exempt criteria is if it's not federally funded, or I should say the federal exempt categories is if it's not federally funded, it's exempt from the regulations. We can't use that exemption. And there are a number of other exemptions we can't use because of New York State regulations that don't allow us to do so. So if you are trying to sign a reliance agreement on an exempt study, we're most likely not going to allow you to do that. You'll have to submit it to the UB's IRB for that determination. So the next level is expedited review. Expedited review is still minimal risk studies, but they may have a higher degree of risk to them. So if you're looking at medical records, there may be the risk that somebody's records might be breached. We have a number of breaches. Somebody sends out a bad email or something like that, has CC'd you on a list of people that have another condition, and oops, all of a sudden people know you have this condition. It's things of that nature. There's a little bit more confidentiality or privacy risk, or if that information gets out, there may be issues associated with that information leaking to the public. Those are kind of the bulk of expedited review type studies. Then there are the full committee review studies. These are the more than minimal risk study. In general, these are your drug and device studies, or if you're testing a condition where there are risks, where you'd be exposing people to risks that are more than minimal risk. Those need to go to the full IRB committee. We have 4 committee meetings a month that meet and review those committees. We have a 7-member committee that will review those and go through those and approve those. And those take a bit longer. So the exempt studies, they take about 2 weeks to get reviewed. The expedited studies take about 2.5 to 3 weeks to get reviewed and approved on average. The full committee reviews at least a month and a half to get approval for a full committee review. So a little bit more serious. I want to talk about minimal risk because I get this all the time. Well, I have a low risk study. I consider it minimal risk. There's not a lot of risk. All I'm doing is getting somebody on the phone and I'm asking them for their HIV treatment. And I consider that, minimal risk. I'm just asking them questions. I'm not doing them anything about their program or about their condition. That's all I'm doing. I consider that minimal risk. That should be exempt. Well, the definition of minimal risk is not great risks that are not greater than ordinarily encountered in daily life. That is the bar that we set for minimal risk. And that's even a difficult definition there because different people, encounter different risks in life, And it goes on, during the performance of routine physical or psychological examinations or tests. So think about, routine physical or examination or tests, You go to your doctor's office, are you going to put a 90-year-old on a treadmill and have them do a stress test when they can't even walk? They'll trip and break some bones. Obviously, the risk of a 90-year-old are much different than the risk of a 20-year-old. So the minimal risk is a sliding scale based on your subjects. And the IRB is tasked with defining what is considered minimal risk or not. That's why, I get this all the time. Well, another researcher is doing a similar study, and theirs was considered minimal risk and considered exempt. Why is mine expedited? I'm doing basically the same thing. Well, you know what? The subject of your study had some additional risk to it, and they felt that it fell in a higher determination. So again, it can be a sliding scale, and we get this all the time. At another institution, they would have considered this minimal risk. You consider this more than minimal risk. Well, and I talk with a lot of my colleagues at other universities, and they all get the same thing. So you're not alone. Each of us institutions is all doing worse than each other institution because I get that all the time. I talk to all my colleagues. I do it all the time. Sometimes I ask them the question, would you consider this minimal risk or not? And I do that. Usually if I have a question, I'll send it out to 2 or 3 other offices that are our peers, and sometimes are higher than our peers or less than our peers. Let's see what they would think and and I can get back sometimes different answers. So minimal risk, like I said, it's sliding scale, but you know what? You have to live by what the IRB says. And if you can justify that your risks are lower, they're willing to listen. They are definitely willing to listen if you come up with a proper justification. So minimal risk. A lot of people, I'm just doing a survey, that's minimal risk. I'm just asking somebody questions. And I talked about this, I'll stress it again. Well, the reason why there are differences in minimal risk are because of a lot of times, privacy and confidentiality. Again, if you're doing a sensitive research subject or something like that, there may not be risk of injury, personal injury, but what if somebody's, data gets out? What if you're working in a field where, alcoholism is you could be fired if you're an alcoholic, or you could be fired for having a condition and somebody's keeping it secret and doing a good job of it. Well, if we let that we let that information slip, then that person could lose their job, or insurance companies could not want to insure them, things like that. Their reputation could be shot, stigmatizing, things like that. We consider as risk and may put it in a more than minimal risk category, even though it's not a physical risk. So, okay. So we'll go into a little bit more details on what the IRB is looking for, things where I see, issues and questions when we're going through what you submit for IRB approval. So recruitment, you're submitting your recruitment poster. What it might be the text of what you're going to say on the phone when you're calling people. What do we want? What are we looking for? What can you say? What can you not say? So first of all, these are the things that we see commonly that investigators question. One of the things is you need to specify when you're recruiting somebody that this study is a research study. We get a lot of pushback from that. And, people don't always want to be in research. So, but the regulations are the regulation. You need to make sure that you state that this is a research study. No ifs, ands, or buts. We get pushback from that all the time. Also need to provide contact information for question. Again, recruitment and consent is a two-way street. You can't just hand out information, have somebody sign and be in your study. Need to provide contact information, so if somebody has questions, they can call and get their questions answered. Also, again, talk about being coercive. You can't be coercive. Compensation is one of the things we see all the time. $50 for this study in large red print. And then at the very bottom of it, in smallest print they can get that I can't even read, are all the risks listed. Can't do that. You can put your compensation in, but your risks have to be in the same font, same color, same size as your compensation. We do allow that. Target population, again, are you just hanging your posters for engagement under the bridge, off of Elm Street, where all of the destitute people who are poor, who will jump at $50 on a study when you can't get anybody else to be part of your study to take place? Can't do that. Won't allow that. We want to know where you're targeting, who you're targeting, things like that. HIPAA issues. There may be HIPAA issues that you may need to address when you're recruiting. If you're going into the PHI, personal health information, which you're allowed to do in some cases to find out if there are subjects, may need to address, do some HIPAA regulations. All right, consent process. So we look very closely at the consent process. When we look at your consent document, we have a big, huge template, about 20 pages that you need to complete. Get rid of some sections depending on what type of study, but you need to provide, I think there's something like 20 different points that need to be covered in a consent. That's actually given to us by the government. We don't choose what points you need to address. They're defined by the Office of Human Subjects Protection Program, and we need to make sure that you cover each one that your study deals with. So first of all, again, I talked about this before, you need to provide adequate information. All the procedures in your study, including ones that you don't do directly on the subject. So I'm going to collect your data, and then I'm going to look at the data, put it together with 100 different subjects, and we're going to come up with conclusions. You need to tell them. You can't just tell them I'm collecting your data, end of story. You need to tell them what you're doing for the whole study, not just with the person themselves. They need to know what all the goals of the study and what you're doing with all of the study. You need to describe the risk. If it's a more than minimal risk study, then you need to describe all of the risks that are known. Also may need to state that, there may be unknown risks that we haven't identified yet if it's a really risky study. See a lot of that with the drug studies and device studies. Can't overstate your benefits. So a lot of times we see, you know, as a benefit in the consent form, you know, we're going to pay you $1,000 to be in this study. Compensation is never considered a benefit. We're going to ask you to get rid of that real fast. Also need to describe the alternatives. If it's a more than minimal risk study, if you're in a cancer study, you need to describe all the alternatives, treatments that are available to those subjects if they choose not to be in the study. In some cases, there may be no treatments, and you're free to state, you know, there are no other treatments. This is a research treatment. We're not sure if it works, but you know, there are no alternative treatments. You can say that if there are no alternative treatments. If you're keeping any data or specimens from the future from any research, yeah, we never want to throw away our data or never want to throw any specimens away if we don't have to. If you're going to keep them for future research, you need to tell the subjects that you're going to keep them for future research. You may need to go back and you may keep that data. You may not be allowed to use that data unless you get future IRB approval, and may even need to go back to those subjects to ask if you can use those specimens or that data. But you need to tell them that you're keeping their specimens or keeping their data for future research, even if that research is unknown. Need to describe your consent process. Where is it going to take place? Is it going to take place, you know, out in the hallway, or will it require you to be in a private office where nobody can overhear because it's a sensitive topic? Need to tell us who's going to be available to answer questions. That person needs to be qualified. That's why we're asking that. You know, we just don't care, you know, well, you know, who? Why do you care who? We need to make sure that person is qualified to answer those questions. That's why we're asking who. How long to decide? We want to make sure that you give a person ample time to decide to be in your study or not. In some cases, that may be days or weeks or even longer than that. In some cases, in an emergency situation, that may be minutes, but you need to provide as much time as possible for the person to make that decision. Consent process. Some additional things. Vulnerable populations. I talked a little bit about this. You may need to use a legally authorized representative, a person who represents the person who is unable to consent for themselves. So people who are unable to consent for themselves or who need additional people would be children, prisoners, people with limited cognitive abilities, and you may need to have an assent process for those people. So those people, even if they can't consent for themselves, say it's a child, you know, a 10-year-old child, he can't consent for himself, but he can kind of understand what's going on. In addition to having a consent document, you may now also need an assent document where you give them a sheet and it's written in language that a child from 7 to 10 can understand. And that child needs to say, yes, I want to be in that study. You will also need the parent consent. And the one caveat to that is if the child says he doesn't want to be in that study and the parent says they want you to be in that study, the child should not be enrolled in that study, or the cognitive, somebody with limited cognitive ability should not be enrolled in that study. There may be a few exceptions to that where it's the only treatment available and it's really in their best interest to be in that study. But in general, if it's an experimental treatment or something and there's no benefit to the person, if they don't assent, even if the legally authorized representative tells them, yes, we want them to be in this study, then they cannot be in that study. Injury compensation is another thing where we look at. It's fine to say, you know what, you're in this study, we don't have any funds to cover if you get injured. As long as they know that, then that becomes their choice. Hey, I'll still choose to be in this study because, you know, I feel the benefits outweigh the chances of me being injured. A lot of drug companies will partially cover. They'll cover things that are directly associated with, you know, with the drug. If they get a side effect or something like that, that needs to be put in there. Along with that injury compensation is going to be some language that is absolutely required. So you may not cover for injuries, but that doesn't waive you from being sued. You can still be sued. A person does not waive their rights to being able to sue you. So if they get injured, they could go to the courts and sue you and say, my injury was a consequence of you, and the courts could decide you need to pay them, even if you stated in the consent form that you have no money to pay for that injury. And then I talked about cost to subject. There may be other costs to the subject that they don't know about. Like I said, things like parking or If we lose your data or something like that, that's more of a risk. But nonetheless, any other cost, cost in time. Sometimes this study is going to take you, 6 hours to complete. It would be considered a cost to the subject.
Dr. Karalus, I wanted to notify you that there's 10 minutes remaining.
Oh, okay, sure. I will get going then. I'm sorry, I apologize.
Thank you. Nope.
All right, I thought I had till 6 o'clock, so my apologies. All right, so bottom line is provide as much detail as possible in your protocol, because that way you're going to minimize the amount of questions and the amount of time we have to go back and forth. Always describe risks. There are always risks, even in a minimal risk study. There are always risks. Usually it's confidentiality or privacy or things like that, but there are always risks. If we see there are no risks to the study, we're going to be asking you questions, and that's just going to delay your approval. A lot of the questions is the answer truly not applicable. A lot of times you really want it to be not applicable, but it really is applicable. So just, don't mark not applicable if it really is applicable. Might need a consent waiver justification for some studies. The IRB will go through that with you if you need it. Non-English speakers, I won't go through that a lot. HIPAA waiver, if you're looking into the PHI, you may need a HIPAA waiver to do that if you don't want to go and ask every subject, I want to look in your medical records to see if you can be in this study. All right. Non-compliance, I'll talk quickly about non-compliance. I see non-compliance a couple of times a year, and it's almost always of the same causes, and some are more likely to happen. So performing study with unapproved methods. I made a change to my study. It's just a small change, but it wasn't approved by the IRB. No matter how minor it was not approved by the IRB. That's serious noncompliance. Performing research without approval. Sounds heinous. Nobody would do human subject research without approval. Well, what if I submitted it to the IRB and you know what? I know they're going to review it and review it and approve it. It's just a matter of time. So I'm going to start the study. I'm going to jump the study. They may want a few minor edits, but you know what? I'm going to start recruiting people. Well, you just did research without approval. That's serious non-compliance. Improperly excluding or including non-English speakers. You have a rare case and somebody who doesn't speak English comes in and ooh, this is a 1 in 100 chance. I'm going to put them in the study. I'm going to do my best with the consenting them and everything. Well, you know what? If you didn't have it in that you're going to be including non-English persons, you just committed non-compliance. Protocol deviations. Like I said, changing minor things, oh, you know what? Mr. Smith I said we were going to see him within 2 weeks after this treatment, but he went on vacation for 2 weeks. So it's going to be 16 days before I can get him in. That's fine. It won't affect the study, but that also, it wasn't approved by IRB. That's non-compliance. Enrolling ineligible subjects. See this very commonly. Oh, you know what? This person fits, 15 of the 16 criteria that we have out there. The 17th or the 16th one, he's just off by a hair. It's not going to make a difference. We're going to enroll him. That's also a serious non-compliance. Unapproved personnel working on the study. See this pretty commonly. I'm throwing, Dr. Smith on the study because he is a great researcher. He knows this inside and out. But the modification has to go through the IRB, and it's going to take a few days. I need him today. I know he's qualified. He's going to work on the study. He wasn't approved. That's non-compliance, and also improper consent process. I talked about how importantly that is. All right. So now we'll go through a few cases. This is just an IRB study that was submitted to the IRB. Investigator proposed to do a study on a new pain control regimen that he offered, and he had a simple study. He basically just wanted 2 groups of individuals that had undergone a painful surgical procedure. It wasn't a serious procedure, but nonetheless caused a lot of pain. And he wanted to look at 2 sets of test subjects, ones that would receive his new pain medication and a control group that would not receive any pain medication. And I simply normally do a show of hands, but I'm not going to do that since we're short on time. Is the study approvable? No. Why or why not? Because the control group needs to receive the regular pain medication that they would have gotten. Even if it's just, take 2 acetaminophen, that's the guidance you give them. Well, you know what? If you're not giving them that same guidance, then that is not approvable. You need to make sure they're getting what's standard of care. Okay, we'll go through some more. I'm going to go through this project because this one is kind of a neat project. And then I have some more, but we aren't going to have time to get it. So this was a malaria project. This is a real project that took place. And I'll give you some background on it. So the goal of this was to develop and test an effective treatment or a prophylactic agent on malaria. So I'll give you a little bit of background at a time, and we'll talk about, does this sound like it's approvable? So first of all, the background is there's no effective treatment. There still really aren't very good treatments for malaria. But the group planned to do only human tests on this project. The subjects to be infected with malaria and or prophylaxed were given new chemicals. The chemicals weren't treated in any animal models. And the subjects they were using were tertiary syphilis patients who had cognitive defects, mentally ill persons, or prisoners. So I look at this study, and we'll use our Belmont principles and look at that. There are all kinds of issues with this study. So they didn't do any animal studies. I'm not going to allow studies to take place, unless you've done as much of the studies you could with animals before you ever look at a human. So right there, that throws a red flag up. We're looking at, purposefully infecting people with malaria. There's a lot of risk with getting malaria, death being one of them. I'm not going to allow you to infect people with malaria unless you have a really good reason for doing so. The subjects we're looking at, that's a whole ball. You're looking at, syphilis patients who have a lot of cognitive defects, mentally ill people who can't consent for themselves. And you're looking at prisoners who should get, special safeguards. So obviously this looks not approvable at all. So now I'm going to add a little bit more, feed you a little bit more on this project. So this project was performed right at the beginning of World War II and during World War II. And the goal was to effect an effective treatment, prophylactic for malaria. And the reason why was because malaria was going to be endemic in a lot of the areas where our troops were going to be fighting. And if anybody knows anything about malaria, it causes a huge issue in areas, causes more casualties than the actual battles would. And for every troops that were infected, it takes two persons to care for that person. So it's a huge strain on logistics and personnel to care for that many malaria cases. So Germany had already developed a prophylactic agent for malaria. Unfortunately, the manufacturing process was protected. We didn't know how to make it. So if we went to war with Germany, we knew we'd be facing them. They'd have the advantage, and so would their allies, and that they would have the prophylactic agent. We wouldn't. So our soldiers would be getting infected with malaria while theirs would be perfectly healthy. We'd be faced with a huge logistics strain. So now all of a sudden it's looking, well, maybe it's a little bit more, more approvable. And there's no good animal model also. So we talked about doing the study only in animals, but there's no good animal model. So, okay, maybe this is a case where we might allow you to go straight to human models. But you still look at those subjects, we're looking at syphilis patients, mentally ill, prisoners, these people are, probably the most destitute and people who just wouldn't understand, and why are we picking them? Is that because they're the easiest subjects to get at and nobody cares about them? That's how it looks. So here's kind of the rationale for why they did this. So winning or losing the war justified the risks. Huge benefit to mankind. If you can cure malaria, then it goes beyond the war. Here's why they looked at the subjects that they looked at. They weren't picking those because they were easy subjects. They knew that high fever sometimes cured even tertiary syphilitic patients. Remember, this is before World War II. We still didn't have antibiotics that could treat syphilis. So if you got to tertiary syphilis, that was a death sentence for you. However, people who sometimes got infected with malaria got such a high fever that it killed the syphilis, and they also improved neurologically. So they said, well, these people are going to die anyway of syphilis. So by giving them malaria, there's, some of them may be cured and there may be significant benefits for them. And they carried that one bit further. They said, well, if high fever can also treat, neurological issues with syphilitics, maybe it could also cure some mentally ill patients. So they gave some pretty good thought to this. So, the subjects might incur some treatment benefits. Prisoners, the reason why prisoners were used was because prisoners, even though they wanted to serve their country, they weren't allowed to. So this was kind of their ability to be patriotic and serve their country. Hey, you can't, you're a prisoner, so you can't serve in the service. But you know what? You can serve your country by volunteering to be in this study. And there was also some degree of they owed society. They committed crimes and we're now caring for them in prison and paying for them. So, they owe society. So that was kind of the reason for it. Would it be approvable in this day and age? Probably not. But again, that was the thought process, going down that study. So I won't go down. I think we're probably out of time now. So I won't go through the rest of the deck of slides. It was another set of case studies, but you can look through the slides and determine it yourself. So.
Yeah, and you have the slides. That's really great. Thank you so much. This was really wonderful. Does anyone have any questions? I think you were extremely concise.
Okay, so I'm gonna go to. I'll kind of sum it up with one slide. So I think, like I said, it's not as easy as we think it was. A lot of times we get scientific tunnel vision. So I can guarantee you none of the PIs, including the ones in Japan or Germany, wished to do more harm than good. They all had kind of a scientific tunnel vision. They felt that what they were doing, the risk outweighed the benefits. And they got that tunnel vision. They didn't, set it out to their peers who would have said, holy cow, what are you doing, Dr. Smith? You are way off base. You're just seeing your own little tunnel vision. You're not seeing the overall picture. So again, differing ideas of good and bad. Our ethics are changing all the time. And there's no better time than now when we see, changes in ethics as far as, society is going in, personal beliefs, the time period, situational, technology. So again, it's becoming harder and harder to decide what is good and what is right and wrong. And you really need to think it out well. So the last, it sounds hard. All of this IRB stuff sounds hard. We have a lot of support for you. If you've never submitted to the IRB, we have either the clinical research office, if you're doing a clinical study, or the social and behavioral research office that you can go to. And they will sit down with you. They will help you complete the forms, tell you what you can do, tell you what you can't do. They will help you submit through our submission system. So if you've never done it before, I wholeheartedly would encourage you and would provide their contact information and have you go and see them to help you. We also have IRB facilitators. If you submit without them, the IRB facilitators may come back to you and ask you, say, hey, this isn't going to be approvable. You might want to look at this before you resubmit to the IRB. And of course, our IRB office, when they perform your review, they're going to go back and forth with you and ask you all kinds of questions and clarifications and work with you. The faster you answer your questions and work with them, and sometimes it's best just to get on the phone. If you're in the click submission system, you're going to get the name of the person. You can look them up and get their phone number and give them a call. And sometimes it's better on the phone than going back and forth in email or in the click system. So, don't be afraid to do that. And you're always free to contact me if you can't solve your problems with all else. Give me a call. Sometimes I can go through them, or sometimes I may just have to tell you, what, that's the regulation. That's what you have to do. It's not something I want to do, but sometimes I do have to do it. So as a note, I'm not part of the IRB. I cannot make the IRB change their determination. I can advocate for you, but when I'm advocating for you, as soon as I'm done with them, I have to tell them I'm not a part of the IRB. If you still feel the way you do, you need to make the determination as you see fit. Sometimes it bugs the heck out of me, but the IRB has to stand independent of the university. So we cannot make changes if we're outside the IRB. All right. So I'll end it right there.
Excellent. Thank you. Well, that's what allows us to be in compliance as well. So that's really important. Absolutely. So we have lots of resources out there. So please feel free to contact people if you need it. And when in doubt, submit to the IRB, because if it's not going to be something that you need for the IRB, they'll tell you. It's actually pretty easy. There's a lot you can skip when you're doing actually simplistic things like surveys.
Right. Most definitely. And if you have a good reason, if you have a study where funding is needs to be given, or what will only be given if you have IRB approval or something like that, get into contact me with you. Sometimes I can expedite studies to some degree and get those approved. Or we have, letters that we can write. Like a lot of times if you have a just-in-time study that gets funded, we have a standard form letter that will issue to you saying, we looked at, you don't have time to put together the study because it's a huge study, but you need IRB approval. Well, they'll forego IRB approval if the IRB has looked at the points of your study, what you want to do. We'll give them a letter saying, we looked at, what, Dr. Smith wants to do, and we're confident that once he submits the study with all the details, that it's approvable. And they will take that in lieu of full IRB approval and give you your funding. That's a pretty common thing. It's called the just-in-time procedure, and that's on our website as well in the Click system, and in our Click library there are steps that you can do, and that we can get you in a day or two. So
Excellent, thank you. Who would be your first contact if there are questions?
actually, if it's a clinical study, if you know nothing about submitting a study, go to if it's a clinical study, go to the clinical research office. You can call Kim Brunton or Pam Anderson.
Right?
If it's a social and behavioral research, something like a survey or something, you might want to go to Chris Marks at the Social and Behavioral Research Office. So they would be your first. If you know nothing about submitting or just have basic research questions, though, that's where I would go first.
Excellent. Okay, so I don't think we have any more questions, so I'm going to end, and thank you very much, and have a wonderful rest of your evening.
All right, thank you, everybody.